Hello, my name is Jorge Cortes from the Department of Leukemia at MD Anderson Cancer Center in Houston. And I'm here to discuss some of the frequently asked questions that I get from some of my colleagues when they're facing a patient with chronic myeloid leukemia. And one of these has to do about when should I change treatment to a different TKI when I'm managing a patient with CML. And certainly because we have many more drugs, this becomes more topical because we do have things to offer to a patient that needs an alternative. I think it is very important that we recognize properly when a patient needs a switch and when it's just a matter of optimizing the therapy. We have very well-defined criteria for failure to therapy that have been defined by the European Leukemia Net that determine when at given times what kind of response you expect for a patient that's associated with an optimal response, and when it's considered a true failure where you should change therapy. So for example, a patient that at 12 months does not have at least a major cytogenetic response, that patient needs to change therapy. And it is important that we follow those guidelines because they have been established based on the information that we have that shows that those patients that meet those criteria are not going to have an optimal treatment, an optimal outcome. It is important that we don't start changing therapy before these guidelines are met, because on patients who, for example, I'm frequently asked, well, my patient is still PCR positive, for example, or my patient has not achieved a major molecular response at 6 months. Well, the molecular endpoints, the major molecular response, we don't expect until much later. And the definitions currently of the European Leukemia Net do not consider the failure to achieve a major molecular response as a failure, not yet. Certainly not the failure to achieve a complete molecular response. So we need to be careful with that. Another important endpoint that has been described recently is the response at 3 months. And it's been suggested that the patients that have more than 10% transcripts at 3 months or that do not have a major cytogenetic response at 3 months have a worse outcome. However, today we do not recommend, or my opinion is that these patients should not change therapy at that point, because we need to keep in mind that the majority of those patients, at least 80% or more, will still have a good outcome. It is important, however, to make sure that those patients continue being followed and monitored closely and check again at 6 months. And if those patients continue falling behind, then perhaps we need to consider treatment change. The other area where we need to consider treatment change is on a patient that's intolerant. But it is important that we consider true intolerance. There are some patients that have adverse events that can be managed, and we should make any attempt to manage the toxicity of the patients, because we need to remember that all the TKIs have adverse events, and just switching from one to the other quickly, that's probably going to expose the patients to just different low-grade toxicities, and we're not going to be getting much, and we're going to use all our treatment options. So we need to make sure that it's a patient that, after optimal management of the adverse event, has not been able to tolerate at all the tyrosine-kinase inhibitor, and then that's a patient that would be considered for switching to an alternative tyrosine-kinase inhibitor. I hope this information is useful for you.